Good morning, panelists and my dear colleagues. Uh, my topic today is AZADIRACTA indica, an indigenous approach against demodectic ocular surface disorders. I have no financial interest. Demodex mite is the most common ectoparasite of human skin, naturally occurring saprophytic arachnid in the human hair follicles and oil glands. In increased numbers, they cause a spectrum of dermatological and ocular symptoms in human beings, as we all know. The most common ocular symptom being Demodex blepharitis. Demodex folliculorum and brevis are the two species that have been identified. Clinical presentation, usually they vary from cylindrical waxy collarettes around the lashes, conjunctival congestion, and even in serious cases present with marginal keratitis. So when we delved into the treatments that are available in literature for Demodex blepharitis, we could find tea tree oil, hypochlorous acid that is used for cleaning the lashes, anti-parasitic agents like metronidazole and ivermectin, eye wipes which infuse tea tree oil and lotilene in a solution, also intensified pulse therapy that's been used for meibomian gland dysfunction. The common practice of application of neem oil to the scalp and face by the rural elderly population gave us an idea to look into AZADIRACTA indica or neem. So as we all know, this has been long used in Indian Ayurveda and Unani systems. It is mainly used in its merit as a general antiseptic. Neem preparations have also been used as decoctions and crushed leaves in various diseases. Neem oil is extracted from the neem seed kernel using traditional cold press methods without applying any heat. So the traditional use of neem oil in treatment of mites, parasites, and ringworms brought in the idea to test its effectiveness against Demodex mite. A peek into the scientific research revealed numerous publications done on the chemical composition and effect of components of neem as an anti-inflammatory, antipyretic, and antimicrobial agent. So we designed a prospective observational study to show the effect of topical application of neem oil, that is neem extract, for patients with ocular demodicosis to know its effect on mite eradication and improvement of ocular surface disorders. So we included patients who came to our OPD who were 10 years and above of any gender from the timeline of January to July 24. Patients who had symptoms and signs of ocular demodicosis were further tested for positive Demodex infestation in via microbiological confirmation. The exclusion criteria involved patients who were lesser than 10 years of age, who had history of eyelid trauma or chemical injury, who were already known cases of chronic cicatrizing conjunctivitis, already on any other treatment for ocular surface disorders, and any known allergies. So the methodology involved, as I told, we selected the patients who underwent microbiological confirmation. The microbiological confirmation was done by taking the lashes and defined by the modified Costin method mounted on slides with KOH, and microscopic confirmation was done for the presence of Demodex. Patients who were tested positive were advised once or twice a week topical application of neem oil extract with coconut oil in a ratio of 1:1 as a facial mask from forehead to neckline. They were advised to keep the face mask for 30 minutes and then wash off. Cautious use was advised without any contact with the conjunctival mucosal surface. Additionally, eyelid hygiene and warm compressions were advised. In few cases, we had to add topical steroids where patients had severity of ocular surface involvement. The outcomes were measured mainly in two parameters after 1 month and after 90 days. The primary parameters involved eradication of mite, that is mite count per eye, and ocular surface discomfort index score, that's the OSD score. Secondary outcomes were evaluated based on the improvement in eyelid findings and decrease in conjunctival congestion and corneal involvement. Toxic effects were also evaluated. So the result of our studies, we had a total of 640 eyes from 320 patients. The study population had 57% of females and 43% of male. The study group was almost equally distributed among all age groups. Clinical presentation showed that blepharitis and MGD were the most common clinical presentation, but conjunctiva and cornea were affected as well in few cases. So among the primary outcomes, evaluation of OSD scores showed a marked improvement from day 1 to day 90. This was further elaborated on comparison when significant improvement was seen even by day 30. The other primary parameter that we evaluated was mite eradication, which also showed a significant reduction from 2.1 to 0.6 by day 90. The significance was visible across all the timelines. Out of the total eyes, 70 eyes achieved mite eradication by 30 days, that is almost 13%, and 24% achieved mite eradication by 90 days. There was a 100% improvement in OSD scores, while 80% of the eyes achieved mite eradication. Among the secondary outcomes, all parameters showed significant reduction. There was a marked reduction in conjunctival congestion. The confounding factor in our study would be that we used topical steroid in 10% of patients who showed improvement in conjunctivitis and keratitis. Out of the 320 patients, we had 3 patients who developed toxic reaction to the medication due to contact to the conjunctival mucosa while application. No allergic reactions were recorded. In conclusion, AZADIRACTA indica neem, due to its proven antimicrobial, anti-inflammatory, and anti-parasitic properties, can be considered a good alternative to tea tree oil for treating chronic ocular surface inflammation caused by demotic infestation in developing countries. Further studies have to be done on the concentration and standard formulation of neem oil to be used, and a definitive test for complete eradication of the mites. Thank you.
Nice study and nice way of presentation. And is this the unique product that your group has prepared, or some other group also uses this?
No, sir. We have not prepared any unique product because the reason why we looked into neem oil was, as I had mentioned, that in the literature, all the treatment were when we advise, it was followed only by a very small group of patients. Many of the rural population doesn't seem to follow the hypochlorous acid cleaning of flashes, and they were not able to follow it. But this was something that they were used to doing, applying coconut oil and turmeric in their faces. So they have this habit. So why not try this? That is something.
Use a face mask to
Yeah,
develop this, right?
basically we're mixing and asking them to apply from neck to, face, head to neck. It's not a mask. Sorry, sir. I think
The way you presented, no, it appeared is some face
once we
mask
apply
there,
it,
yeah.
it thickens and it will be like a face mask. That's all.
Okay.
Duration of study from January
months,
to
sir.
6 months.
We took 6 months.
Number
And
of
then
624 cases. The incidence is so high, no? Which area you have selected?
so we are taking patients from in and around Coimbatore.
620 patients.
Yes, sir. We have seen.
Incidence
We
is
were
quite
also quite
high.
surprised, sir.
Yeah, that's why I asked for him. And then you said no, not much of complications. Only few complications.
Many of the patients
Toxin.
developed kind of sensitivity once they touch the conjunctiva mucosa, but 3 patients were significant. Like even after we asked them to apply it carefully, they were having the problem.
So ethical committee submitted that.
Sir?
Ethical committee is
So
cleared.
we are not yet applied for this thing because the formulations have to be finalized and then to do a.
You've done a study.
Okay, sir.
You cannot do the study and get an ethical committee. You have to do the ethical committee first before.
But then only.
Otherwise, your study won't be valid.
Yes.
It's a very, it's a very unique study. It's very novel.
Yeah.
2 things you need to do. The first thing is, as sir said, you need ethical committee clearance because you're doing an intervention.
No, sir. This has been done by our institute and it is cleared by the ethical committee of the institute.
Yeah,
Yeah.
that's that.
Oh, sorry.
That is the question.
No. What I was telling was we are the next part of the study is to define the formulation and percentage and then to.
You can also, my only addition to that would be, please introduce a control. So the control could be tea tree oil, which is already an established, treatment process.
Yes.
Not the commercial available tea tree oil wipes. See, when we treat hemorrhagics at our place, we get tea tree oil, organic tea tree oil, which is actually like, again, cold pressed and this thing. Tea tree oil by definition is quite toxic. Yes. When you apply it, it's got a very pungent odor, and it, like you said, it causes severe medicamentosa. So the same thing, you'll need to see if this is as toxic, because it will be, because it's an organic compound. It's going to be. So you can have 3 control arms, 3 arms basically. One would be your neem, one would be tea tree oil, and the other one is the conventional, just the steroid and the lubricant method. See which one's better, and mite eradication. Symptoms, your secondary outcome is not that important, because that is, again, there are a lot of things that are confounding that outcome. affects the patient as well. So if you have keratitis, you got to have to put a steroid.
Yeah.
So look at it in 3 arms. You'll actually have a really good paper that you can come out with. That's very nice.